very lucky that at one of our recent WCIT Medicine and Health panel events, one of the subjects that keeps cropping up in our regular monthly meetings is the subject of electronic health records and how difficult and complex it seems to be and has been for since time immemorial. And I was very lucky that I was approached by Gilbert at a recent event, and we started talking on the subject. And it turns out that he has quite a similar career to mine, and that he spent the first X number of years working in the vastly exciting area of banking and technology. But then it turns out you'd done a lot of very interesting work in electronic health records, and you seem to have very practical experience. So I asked you a bit more about it. And then it turned out you'd actually co-authored a book, which it's not often you get someone coming and talking to you who's actually written about a book about a subject which is of particular interest to your panel. So I pounced on the idea of getting him along to come and make a presentation. And he also kindly suggested that we also involve his co-author, Ken, who appears to be not only highly qualified in a military and medical sense, but can also give a unique perspective of the US health system and the unique challenges, for better or worse, that presents. So I think we're really, really lucky that Gilbert came up and spoke to me that evening, and it's ended up with this. So thank you very much for doing this. I'll hand over to you now.
Okay. Shall I go straight into it? Or
Yes, please.
Okay, well, I thought, thank you very much for that introduction. Ted, I'm going to start by just saying a little bit about myself. I mean, I think everybody knows me as an individual, but as Ted pointed out, my IT background is quite varied. I started life in banking. I spent the first 20 years designing banking systems. I worked in the Middle East for most of that time and designed some of the earliest banking systems in the 1960s, 1970s in a number of countries in the Middle East. Then I got tired with that, tired with the Middle East, tired with banking, and moved back to the UK, I should say, in 1983. And I started, that coincided with the shift away from large mainframe computers to smaller machines. And at the same time, I was looking for something new to do and got involved in medicine. And in talking to doctors, I discovered that we had this opportunity of looking at the environment where a doctor and a patient is a small group doing specialized work that fitted a PC much better than the mainframe type systems that we had before. So I then ended up spending 20 years developing medical record systems. And I sold that company to Reuters in 1997, by which time I discovered that the NHS doesn't buy the systems it needs, it buys what it's told to buy. So in fact, I felt I'd wasted my time for 20 years, but that's another story. However, after that, I then got involved in the United States in a number of projects, and that's how I met Ken, who will be talking later on. And part of the book is what we did together. And I'll be introducing, I introduced Ken as a interesting partner of mine in that we have very little in common. He's American, I'm British, he's a doctor, I'm an IT person, but we found we had a very similar view in the fact that electronic health records were not doing the job that doctors wanted. And I think the analogy one of the analogies we came up with, imagine a world where a pilot is sitting in an airplane surrounded by computer systems that do freight management, do booking, do scheduling, doing everything. But the pilot's sitting in the front of the plane with a few levers and things without any computers anywhere near the cockpit. I mean, that's the way I see the health business today. So my view of having worked with the NHS and also subsequently working with the US, and Ken shared this view, is that if anything, the systems that doctors are using today in hospitals, and I'm talking primarily in the hospital environment, they're more of a hindrance. I think Ken will probably mention this himself, but it struck me that we've got a situation where a doctor has 10 or 15 minutes to talk to a patient. He's spending most of that time tapping away at the computer. That was my experience last year. I went to go to hospital. so that's really where what the book covers. That neither of us think that today's EHR meets the requirements of doctors, and that actually this has been the case for the last 40 years. Where the NHS is still buying systems that are not helping doctors; they're helping the hospitals. And so the book we've written really covers that. And it's, let me just check my notes. Yeah, the book is in 4 parts. And interesting enough, 4 is a magic number for Native Americans. It's in 4 parts, and it represents 4 views. It represents the view from the United States, represents the view from the UK and Europe, in the sense that that's state medicine. It also represents the clinician's view as opposed to the technologist's view. Which is my view of what's wrong with EHR, as opposed to Ken's point about what's wrong with EHR as a user. So the book itself, which I'll just describe and then I'll pass on to Ken, we go through one stage talking about early EHRs, when I started working in healthcare, when Ken was working in healthcare, the promise of early computer systems in healthcare. We then go on to a project that Ken and I did together in Korea that was very interesting and may have ended up having something to do with the fact that the Koreans dealt with COVID better than anybody else. Then the third section is about how we got into this mess. And Ken's going to deal with those 3 parts. And then I'm going to finish off by talking about the way forward, how we see that we could improve things very rapidly and relatively easily. So that's where we are. So now I'll pass on to you, Ken. Okay.
Oh,
thank you.
Thank you, Gilbert. I'm honored to have been invited to be virtually with you in the City of London, and thank Gilbert and Rosie Woodhead for making this possible. And thank you for introducing me and providing the background for the book. And just starting off, throughout my 50-year now history, clinical career, my goal has always been to provide the best possible care I could for every patient I see. And remarkably consistent over time, the office time constraints for an appointment have been all the same. I have about 30 seconds or so to figure out what the patient might need as they're coming in from the waiting room, about an hour for a new patient, maybe 15 minutes for an established patient. Which also has to include all the documentation, which should be completed by the end of the visit. And from the very beginning, I was just enchanted with what the potential would be for a computer and EHRs to genuinely improve the quality of care, and had some unique opportunities. So Gilbert, I think, obviously instinctively understood that clinicians needed an EHR, which he developed template, which what you see here is a screen in our project from 1998, where he takes a guideline, which the medics have to use, which is about as thick as the book that you have, and now automates it in a way that's like a flow diagram. What's the complaint? And basically the medics have like a few minutes to make some pretty critical triage decisions, and that's what was in the guideline. Now earlier in 1991, where I come into the picture, was I was given a really unusual opportunity to look at the Army's alcohol and drug treatment programs that were all pretty heavily regulated. And the diagram you see is from a methodology that was actually used to in aircraft manufacturing. The government wanted to know how we were spending our money. And they said, well, we make an airplane. What else do you need to know? And so they came up with a flow diagram, which would break down, here's the critical work, or here's the work you're doing, actually, the controls. And for medicine, the mission really was to take care of patients. It was for the morale of the active duty force. You have to take care of the families, you have to take care of the person, you have to take care of the retirees, or they're going to be demoralized. So that really is that's in the preamble to the laws that govern healthcare at the time. That was true, and it looked a lot actually like a European healthcare system. And then coming in from the bottom here, You have the cost, basically the resources which have costs, and privileged staff. It's not just anybody, but you have to be trained to take care of patients. But also, this is where the automation could come in. And then what are you doing? The work changes. You don't know who the person is, and then you're going to effectively treat that person, hopefully successfully. And this input output really could translate to the data that you need to know in order to provide good care. So that's where we start. And lots of words here, but basically it's what is the definition of an electronic health record, which is very similar in terms of what a clinician needs. It helps me take care of a patient, basically. It helps me communicate. It documents what I did, and it should do it efficiently. And more importantly, also that an electronic health record now has the capability, or should have the capability in this definition, to give the patient a lifelong health record wherever they go, whoever they see. The people involved with that patient has exactly what they need in order to provide care. And in that points of light in that first section, what is over here was an intensive care interventional cardiologist, Michael Lesser, who had programmed an electronic record. He could take a very complex cardiac exam and compress it to about 2 pages. And this homunculus here, green, amber, well, you don't see the amber, but the red, he could pass through a ward of 20 patients and know exactly what was wrong with each and every one of them and what was going well and what they needed right now. I don't see a display like this in any EMR that I see today. But this was, and this doesn't exist. He's also, the concept didn't take off. So what are we left with? This is the problem today, is that we're designing things around the administrative and business needs of every facility to generate income, basically. So as a patient, I'm getting fragmented all over the place. My value as an inpatient, I'm going to be acquired, I'm going to be assigned to some provider. They're going to determine what the value is of the reimbursement potential. I get treated, it gets documented, and I get discharged. And I go to an outpatient setting, and the same thing happens again. Who are you? Why are you here? Here's a provider treat, and documenting. Its codes are going out, but where's the important information about the patient? The other piece of that is that you have health is going on all over the place in terms of healthcare. I can go to a gym. I can go to the work site has training, occupational health. And all of that information doesn't even get into the medical records, really, on the most part. Everything is fragmented. And the clinician, the motivation of a clinician is to take care of a patient. So, the EMRs are kind of getting in the way. The paper sometimes got in the way. And so, is this information actually reliable? And, I have a diagnosis, but where are the signs and symptoms and the inclusion criteria, the exclusion criteria? That all can be missing. So how do you use that information for anything? And this is just highlighting, I think, the chaos. You have here, I've defined where the provider, here's a primary care provider. The reports, I'm saving paper, I'm putting things into a machine. Other people are also involved with the patient, occupational health, maybe the employer, and all this information is just fragmented all over the place. And ultimately, okay, what's the healthcare system doing? You're getting billing codes, basically ICD diagnoses or procedure codes, and but that's all you have. And you go to another system, they have their thing. Everybody has their own thing. So in our Korea case study, I'd say a study, a lot of experience going into Korea, and what was concerning to me was we were starting a mandatory anthrax immunization program, and I knew from 1991, this is now 1998, that there were a lot of complaints and concerns about the reactions, and so my thought was, well, we could capture that in a structured note and help the provider take care of a patient, the same logic that we'd used in our drug and alcohol program, actually. And we could figure out, and it only took about 400 or so people being seen to realize there's a male-female difference going on. Anyway, fast forward into this project that we had. From a command standpoint, who's sick where today, and what do they have? That could be important. If I were to mobilize the troops and in a camp everybody had diarrhea, they're not going anywheres. And this was information we didn't have. So that triaging algorithm, which is now automated with a template, can produce something for the record, which is which is in a standard form that patient can take with them. But you can also take that information and push it into a GIS, a mapping system, and this existed at the time with DARA, that they've done this in 1991 also. And this little thing up here was a handheld that the soldier could take into the field. And if they get a headache or they're feeling a respiratory, that could be something going on too, and that could get transmitted. Well, today we have our smartphones, smartwatches with applications that can collect that kind of information and map that kind of information, but you can't do that in an EMR, and it doesn't feed the EMR. So that's the Korea project. And I'd let questions answer, but just kind of the overhead and this was just it was actually very inexpensive. That's what we were kind of finding, is that the right solutions with the right focus was really a whole lot less cost than what people were expecting to spend, and that actually is an interesting problem. In the cure, and this is and this was like, this was in my head as I went in. These were things I learned from our drug and alcohol people, that that was a program that was actually returning about, in a published study, 90% were on active duty with 80 or so percent abstinence at 1 to 2 years, and a 13-to-1 return on investment. But they were doing a comprehensive biopsychosocial assessment. So you have your biological factors and your psychological factors, and we have medications for that. But we also have therapy for that. But the third dimension, which we tend to miss, the social determinants of health, are here. And all of these factors factor into, do I get better? And it can be an addiction problem. It could be my blood pressure. It could be diabetes. But what you're doing day to day, 168 hours a week, and who your friends are and what you're doing all factor into whether or not you're going to get better. And if I focus around the person, whether they're in the healthcare system or in a wellness program or an employer health program, all of that information should be available to the benefit of the patient. And over time, I can change my guidelines based on what I've learned from the people I've seen today, but also the people that have been seen by everybody else. And so this is the notionally, the conceptual for patient-centered EHR is over here, where basically the people best able to provide information. Now you can secure it, and in the beginning, Henry Camp was a gem in the area. He had, for him, a down system was a dead patient. So by 2008, which is when his system was taken off in favor of one of our big programs, one EHRs, he had 1.5 million patients in the system with no downtime, no security breaches, ad hoc query potential, 1-second retrieval times. And I've yet to use an EMR today that can do any of that. So yeah, I'm frustrated. A lot of clinicians are frustrated with what we're given to use without really having the input to, do you understand what I need? So fast forward, my last assignment in DOD was the medical director for population and health improvement. And here's a notional, the alpha to omega kind of a thing. From the beginning, when I joined the military and our drug and alcohol, they were already they already had a process that looked like this. But this is really developed. This MHS could be a medical, mental health, military health system, which are operating clinics, but also based on a community, which you hope is healthy. And it's that the policies and the environment and the individuals in that community and their access to healthcare, that really is what the healthcare system needs to connect to. And in the plan and guide 2001, that was kind of described. And then they would just say, okay, well, we have this automated system, we have this electronic system, we have this EMR, and this is going to provide data for each of these 7 steps. Well, the problem is that for each identified product, none of them really met the data needs for the 7 steps for population health improvement. So, the data support for this model really has yet to happen. So with that, I'll turn it back over to Gilbert for his comments. And I want to, anyone wants to review any of it, I mean, I can go back to any of it, but I was concerned that there's so much there that we can learn from and look at the future.
So that covers the first 3 sections of the book, and then the 4th part of the book, which again, we co-wrote all of it. So let's say each section, there's Ken's bit and my bit. The conclusion we came to, having gone through that process, both in terms of our careers and in terms of what we've written, it's pretty obvious that a patient record has to be exactly that. It's one record, it's one database containing one person's all health information. Collect everything into one database. That's to some extent what I did with the template system we did. We were able to run different applications off the same database, which was patient-based. Today, with modern technology, with the internet and with websites, it ought to be possible to create a depository of one person's health information, irrespective of where they get their health, irrespective of what country they're in, and so on. This is cradle to grave health record that has been talked about. And then the other part of it would be that you then build applications that access that data and give the clinician what the clinician needs to see from it. And those would be separate applications. So you've got an application for whatever that clinician is doing. And as I said, the book goes into more detail how we do that. Otherwise, it wouldn't be a book. But the idea is that we're not talking about something that replaces current EHRs. We're talking about something that something that clinicians use that sits on top of or beside the existing computer systems. So it draws information from it and passes information back. And also the way we describe the implementation of this, it would be very easy to get started and to do it. We're not talking about a huge amount of money. We're also not talking about anything that's disruptive. You could actually grow it alongside what we've got now. That's the concept. Right, there we are.